Good evening, everyone. I'm Vicki Wilkins, and I'm the Dean of the School of Public Affairs here at American University, and I'm so delighted to welcome you to tonight's event. We have what is capping off our academic year in the Sine Institute for Policy and Politics. We've been so fortunate to have Dr. Abdul El-Sayed with us as an inaugural fellow of the Sine Institute. And tonight, he brings with him a special friend and someone we're all going to want to hear from. Representative Jayapal is here with us tonight, hot off her hearings and work that she's doing on Medicare-for-All, to speak and share her views with us here. We're going to do some conversation together and take some questions at the end. I thank you for being here. Enjoy.
All right, good evening. Good evening. All right, fantastic. We're about to talk about healthcare, and that's everybody's favorite topic. So really, really excited to have the opportunity to share in conversation with somebody whom I've respected and looked up to in this policy world. I want to share why the conversation, I think, is so critical and so critical right now. I'm a doctor by training, and I remember my first rotation in medical school, and one of the first patients I ever took care of was somebody who landed in the hospital because they were rationing their pills. And this was not somebody who did not have health care. They just didn't have adequate health care. They were underinsured. And the conversation that we're having today is yes, about the technical question regarding a particular set of policies, but also about the moral question of whether or not we as a society want to stand up to talk about and raise up a conversation of what it might look like to dignify a human right to health care. Now, I'm not saying that Medicare-for-All is the only model to do that, but that is the one that we are talking about today. I ran for governor, and when I ran, we ran on a single-payer platform. And that platform was about asking a basic question of, can the state of Michigan, my home state, provide every single Michigander access to the right to health care? And we struggled mightily with the questions of how much might it cost? What would it look like? What is the point of care? How do we make sure that the technical details of a just transition are taken care of? And we put forward a platform. Now, the interesting thing about it was, when I ran, we made the decision to focus on not what it would cost the state of Michigan, but what it would cost the average family in the state of Michigan. The dollars and cents that most of us think about. And when we talked about it, so much of the conversation resonated because we were talking about those numbers that people actually thought about. How much comes out of my paycheck? What do I have to pay when I have a conversation with my doctor? Do I have to jump on the phone with some executive or some bureaucrat from Blue Cross Blue Shield to actually get access to the health care that I, in theory, already paid for? These were the questions that so many Michiganders were thinking about. Now, at the federal level, this is obviously a far bigger lift. We were talking about 1/50th of the United States. We're talking about the entire United States, 350 million lives. A question of providing everybody access to what is unfortunately right now some of the most expensive healthcare in the world. Our conversation today will be both about the morals and about the technical questions on this particular bill. If you've been watching, today's a very unique day to be having this conversation. Today, for the first time, there was a hearing about this. And I look forward to sharing that conversation together. I want to now introduce the guest of honor for tonight's conversation, Representative Pramila Jayapal from the 7th District of the great state of Washington, the second best state in the entire country. And prior to her service in our Congress, she was a state senator from the 37th District of the state. And prior to that, she was a civil rights activist and advocate, founding One America, an organization to combat some of the racialized anti-immigrant policies that we've seen, unfortunately, promulgate themselves in this particular moment in our country, in a moment that I remember really well because it was just after 9/11. Her service goes back many years. We're profoundly thankful for it. And with that, I'll cede the stage, let her talk a little bit about where we are, where we're headed, and we'll jump into the conversation.
Thank you so much, and good evening, everybody. It is just wonderful to be with you. I want to say thank you, Dean Wilkins, for your commitment, for having me here, for the wonderful work that you're doing we just could not be more fortunate to have such a brilliant fellow here, first fellow here with Abdul. I watched him on the campaign trail. He was charismatic, intelligent, brilliant, all the things that we want to see in candidates, and deeply appreciate your talking about healthcare as a critical issue as you were on the campaign trail. So I can't think of a better moment to have this town hall than today. We had the first ever in the history of Congress hearing on Medicare-for-All in the United States House of Representatives. And it was an incredible hearing, and we'll talk more about it during our conversation. But, you know, making history by having a debate about the critical issues facing us as a country on healthcare and a real plan to move us to a universal healthcare system was, for me, just a remarkably hopeful moment in our country at a time when perhaps it seems like there's a lot of darkness around us on a lot of different issues. Over the past couple of years, we've seen with a greater urgency the need to address this economic issue, pocketbook issue, and human rights issue of healthcare, universal healthcare. Every day, the American people directly see and experience the impacts of a broken healthcare system. We heard about it today on the hearing, but we hear about it every single day. We talk about and hear about from my own constituents, but from constituents across the country, about how people are making choices between insulin treatments, paying for insulin treatments, and paying for their mortgage, between getting care that they know they need at the emergency room and having to declare bankruptcy. People are using GoFundMe campaigns as their insurance program. And when you think about that, and you think about the fact that the United States of America is the richest country in the world, we spend 18.5% of our GDP on healthcare costs. 18.5% of our GDP on healthcare costs. That is almost double the amount of money that is spent by any of our other industrialized countries, peer countries. And you might think that if we spent that much money on healthcare, then we must be getting the greatest outcomes. But in fact, the United States of America is the leading contender on maternal mortality rates. We have the highest infant mortality rates, and we are the only industrialized country in the world where life expectancy is going down and not up. So our outcomes make us look at this system again. Every day, too many Americans are sick and dying because they can't afford health care. And when we look at this issue, we have to think about the fact that the United States of America is a country that ended slavery, sent a man to the moon, gave women the right to vote. We certainly should be able to provide universal health care for everybody. Part of what we have been trying to do as we've moved this debate along is to look at the healthcare system we have today and take on some of the barriers that have been put there by the people that benefit from the existing system as it is. Primarily big insurance companies, big pharmaceutical companies. And so when you hear that Medicare-for-All is unaffordable, the first question you have to ask yourself is, what does healthcare cost today? If we were to move to a Medicare-for-All system, what would it save us over the course of time, over the next decade? And what would be the benefits that we would get? I am here doing this work, and this issue is taking up a tremendous amount of my time, not all of my time, because I'm also working on immigration reform. I'm also working on a whole host of other issues, economic inequality issues. Healthcare is deeply related, by the way, to that. But I am here because I fundamentally believe that healthcare is a human right. It should not be available only for the wealthiest few. We should not have a system that has two tiers of healthcare. One tier of healthcare, which may mean nothing. We have 30 million people who are uninsured in the United States of America, 40 million people who are underinsured, which means that they're not getting the kind of insurance that they need when they get sick, and the people who have insurance, tens of millions more who simply can't afford to get the care that they need, even with the insurance that they have. So I believe we have to do better, and we can do better. And so this bill is the result of a long process, and we'll talk about it in our conversation. But I want to tell you what my bill, the improved and expanded Medicare-for-All Act of 2019 actually does. First of all, we cover everyone. Everyone. Nobody out, everybody in. Whether you're rich or poor, if healthcare is a human right, it can't be a human right only for some. So we cover everybody. Second, no co-pays, private insurance premiums or deductibles, and you can see any doctor or hospital that you want to see. We want you to go to the doctor when you're sick, early, maybe even before you get sick. Have the kind of care that allows you to do prevention, not curative care, which is far more expensive. If you have to end up going to the emergency room, we want you to have preventive care. And we don't want to change the provider system at all. So when you hear that it's a government takeover of healthcare, that's a great Republican talking point, but it isn't true. Because what we're saying is the same system of doctors and hospitals would still be the system that we would utilize. The only thing that changes is you don't deal with the insurance companies. Third, we provide comprehensive care. Primary care, vision, hearing, dental, prescription drugs, mental health, substance abuse, maternal health care, and more. And finally, coverage will be based on medical necessity rather than what insurance companies are willing to pay for. Fourth, and this is a very important component that I think we're going to talk a little bit more about, we control costs. You have to control costs within the system in order to address the holes and the issues within our current healthcare system. So we estimate that the average family, often paying thousands of dollars in copays, insurance premiums, deductibles, could actually pay 14% less under our plan and get the comprehensive care that they need. And finally, and this is a really big one as well, for the first time in history, the Medicare-for-All Act of 2019 includes long-term care. And this is very, very important because we have got to take care of our folks with disabilities and our elders across the country. And so this is a key piece. Now, is it a bold, ambitious plan? Damn straight it is. Excuse my language. It has to be. If you look at the scale of the healthcare crisis, the way in which this is a pocketbook issue for Americans across the country, in many cases the number one issue for Americans across the country, we have got to have a plan that addresses the core deficiencies, the core sicknesses of our current healthcare system. And so we know what's going to be thrown at us. In the hearing today, we talked to Chairman McGovern, did a fantastic job, and he talked about how, the terms socialism, socialized medicine, socialist, that's been thrown at everyone, going all the way back to Teddy Roosevelt, Harry Truman. We've all heard that term. In fact, that's what Medicare was called. That's what Social Security was called. So we're ready for that. We're ready to talk about what should the government's role be in providing health care. One of the things that has been so phenomenal about where we are today is that the coalition has just continued to grow. And it's continued to grow in part because of candidates like Abdul that talked about universal health care on the campaign trail because, of course, of Bernie Sanders in 2016. This time around, many presidential candidates talking about Medicare-for-All, but it really has been because of the movement across the country. And the people who have shared their stories about the healthcare crises that they're facing, that their mothers or fathers or daughters or sons or sisters or brothers or aunts or uncles are facing. Those stories have energized a movement across this country where we have doctors, we have patient advocates, we have nurses with us. For the first time, we have a robust coalition of labor unions that had not previously signed on to Medicare-for-All. We worked very hard. This time around, we have SEIU, AFT, NEA, UAW, the mine workers. It really is a phenomenal coalition. This time around, we worked with disability rights folks to make sure that we got the long-term care piece right. We worked with immigrant rights folks. And so the energy across the country has been phenomenal. And if we are going to win on this issue, and I believe we can and we must, it will take that energy across the country. I know that I was thinking today in the hearing as I was listening to Adi Barkan, who is an incredible activist and just has a few years left to live. He's been diagnosed with ALS and just had the most powerful, compelling testimony. As I was listening to him and then listening to the whole hearing, I was thinking about Dr. King, and I was thinking about his words around the urgency of now. And I was thinking about his I Have a Dream speech, where everyone knows the big parts of the speech related to I Have a Dream, but the part that I love is when he talks about the dangers of the luxury of the tranquilizing drug of gradualism, the luxury of gradualism, the tranquilizing drug of gradualism. And of course, he's talking about it in the context of slavery and coming out of the darkness of slavery into the light. But I thought about it in terms of how we think about the change we need to enact and what it's going to take. So I'm really looking forward to this conversation, and I think it's going to be a robust one, and I can't wait to get to your questions as well at the end of the evening. So thank you so much for having me here, and let's get at it.
Okay, so big day for Medicare-for-All. Can you just tell me what your thoughts were throughout the conversation? What went right? What would you have liked to see go differently?
Well, having a hearing was a huge thing, and we got this agreement. I was able to work early on in the session to get an agreement from Speaker Pelosi to have hearings on my Medicare-for-All bill. And that took a lot, but she has stuck to that commitment, and so this was the first time to have a detailed hearing. And so part of what we had to think about was, what witnesses did we want to have? What pieces of the story did we want to tell? We had patient advocates, we had we had a doctor, an emergency room doctor, we had an economist, a really well-known economist, we had somebody from the Commonwealth Fund, and then we had Adi Barkan. And we were able to really deal with the different pieces of it. If people wanted to get technical, we got technical. It was a detailed discussion, and I just have to say I had so much pleasure in seeing a civil dialogue, and I will say that the majority of the Republicans were incredibly engaged. They asked good questions. I didn't agree with everything they said, but it was a real discussion. It was a real debate. And at the end, the ranking member Cole, Republican member Cole, thanked McGovern and said, you know, this was a real discussion. Thank you for having this conversation. We should be talking about this issue. And so I mean, maybe there's a couple of things that could have gone differently, but I really was just so thrilled with what happened today. And shortly after that, or actually during the hearing, we had another meeting with Chairman Neal of the Ways and Means Committee, and I got a commitment from Richie Neal that Ways and Means will also have a hearing. So this is just the first. We're going to go to budget, we're going to go to Ways and Means, we're going to go to Energy and Commerce. We haven't yet gotten that commitment from Frank Pallone, but I think we'll get it. And we will move this conversation further so that people really understand what is in the plan, what is the problem with our healthcare system now, what is the diagnosis, doctor, and then how do we fix it?
Yeah, that's fantastic. So we've been hearing a lot of conversation about the term Medicare-for-All, and we're hearing commitments and then maybe decommitments, commitments with big asterisks of various sizes from various folks running for president. And I want to understand, in your mind, how do you define what Medicare-for-All is? What is the standard to which you are holding presidential aspirants when they say, I'm for Medicare-for-All? And how does that differ from some of the other plans being proposed?
Well, first of all, it has to be universal. I mean, you can't have a Medicare-for-all plan if it's Medicare for some. Medicare for some is not Medicare for all. So Medicare for all is universal. It covers everybody. It has to take into account some of the sicknesses within the current system, which means that it has to address costs, and it has to address the role of for-profit private insurance companies. It has to address the role of pharmaceutical drug companies. And so in our bill, we include Lloyd Doggett's excellent bill on pharmaceutical drug pricing, which says not only that, yes, we should be able to negotiate drug pricing for Medicare, just like we do for the VA, but also that we would put in not just the carrot of negotiation, but the stick of compulsory licensing. So if you look at our patent protection monopolies and what that has done to the price of pharmaceutical drugs, not just prescription drugs, but all drug pricing in the United States, significantly higher than any other of our peer countries, because we don't do anything about the cost of those pharmaceutical drugs. So we include that in the bill as well. And I think all of those elements have to be within the bill. I want to just say one thing I forgot to say about the hearing, which is it would have been a different hearing had Adi Barkan not been there. And for those of you who didn't have a chance, how many of you were able to watch a little piece of the hearing today? That's wonderful. If you didn't have a chance, or if you missed Adi's beginning testimony, but also his commentary throughout, I would just really encourage you to watch it and to look at the courage and the bravery of this young man who has very few years left to live and is brilliant. With all that he is dealing with, is still intellectually brilliant, but also put it on the table every day that this is not a technical, technocratic question. This is about life and death. It really is. And to be reminded of that and the urgency of now, I think, is very important.
Yeah, I got to know Adi when I was running, and he came to campaign with me. He has a son who's about a year older than my daughter, who's 17 months. And he was able to speak because of technology that allows him to look at a letter and place a letter in Word. And he is somebody who has spent the last couple of years of his life dedicated to this issue. So to hear him speak his truth and what he wants for his kid and what he wants for his kid's kid, I thought it really, it spoke to accentuating the moral question.
Yes.
Getting into some of the technical questions that everybody likes to talk about. You know, I've heard healthcare described, and I really like this description, as a series of micro-oligopolies. And the reason why is because there may be many hospitals, but if I started clutching my chest right now, there's really only one hospital you all would take me to, which is the nearest hospital. And at that point, I'm, in effect, a hostage to what that hospital wants to do for me, what that hospital's operations look like, and my own insurance, which if I wanted to change, I couldn't change in the moment. Like, wait, I had a heart attack, give me the better insurance, right? And so much of what's frustrating about healthcare is exactly that, is that at a micro scale, there's oligopolistic behavior on both the provider side, i.e. the doctors and the hospitals, and on the payer side, which is insurance. Can you talk a little bit about two things? A, the structure of Medicare-for-All itself, the imposition of a monopsony on the payer side, and then B, your focus on global payments, which I really think is an interesting and important innovation, and how it would address that micro-oligopolistic behavior locally.
Yeah, well, I'll start with the second piece, global budgeting. This was something we put into the bill. We looked at all of the bills that were out there, and we took the best parts of what was there. But one of the things that really wasn't in very many bills was this concept of how you control costs. And if you are going to have an effective healthcare system for the long term, you have got to deal with this cost question. And so what we did is we put in a system that is used in many other developed countries. We're actually testing it in Maryland. Maryland has been testing it with a lot of success, and actually is just about to expand it to acute, or maybe has already expanded it to acute care hospitals. But basically what we're saying is about a third of the costs are wasted on administrative, billing, etc. costs. And so we can save on those costs by cutting out certain parts of the system, but then also saying to hospitals that you would get a negotiated amount that was not a patient-by-patient amount, but is an overall amount that is determined by looking at a lot of different factors: the history, the number of patients that your hospital sees, some future trends, and that amount then is your global budget. And it ends up being a great cost containment measure, but it also is a very critical savings for a hospital to have a certain amount of money that then they work with. Now in Maryland, people say, well, what happens if it's not enough money? Well, if it's done properly, it will be. In Maryland, they found that they really didn't need to make any changes. There was a process in the plan so that if you had, say, a dramatic outbreak of measles, since we're talking about that right now, and you had a lot of people suddenly streaming into a hospital, there is then a way to go back and say, wait a second, we need to negotiate for more money so we can take care of this. But what happened in Maryland is they found that they really didn't need to change the amounts that they were assigned. So it works really, really well. And so that was a big innovation in this. And the Washington Post, actually, right after we introduced the bill, we all had predictions about what people were going to write about. The Washington Post did a fantastic piece, I think it was the Washington Post, did a fantastic piece that really dove into global budgets, which is pretty wonky. I mean, you're interested in it, and obviously some people here are interested in it, but a lot of people don't really understand. And the Republicans and people who want to tear this plan down will say, oh, that leads to all kinds of bad results. But no, in fact, it's something that's very successful, that's been used, and is really, really important. Your other question was about the payer side. So you're talking about the insurance companies and the government piece of this. Well, again, we are wasting enormous amounts of money on administration that is being provided through the insurance companies. So this is, you buy a plan, right? And then the insurance company says, we're going to insure risk. Well, there are a lot of things that I don't want to go to the government for. I don't want to buy my coffee from the government. I mean, I do come from the land of Starbucks. But I don't want to buy my coffee from the government. I don't want to buy my computer from the government. But on something as critical as health insurance, I don't want to leave that to a for-profit insurance company. So if the government covers that insurance piece and you cut out that middleman, then you have an incredible amount of savings. And you still get to see the same doctors. In fact, I would argue you get to see more doctors in hospitals because there's no in-network, out-of-network piece to this, right? So those are the two big components of this. I mean, you will hear government takeover of healthcare, just not true. How many people have had or heard of somebody close to them who had a serious medical problem, went to the insurance company said, I'm not going to cover that, or they said, well, let us have our doctor tell you what should be covered or shouldn't be covered for your personal treatment, somebody who's never seen you before. And all of a sudden, it gets determined that you don't deserve whatever it is your doctor has prescribed. That won't be the case with the system we're proposing.
So one of the big scare tactics that a lot of folks use, and I hate to say it's both on the right and the left, is that when people learn that in Medicare-for-All, the system would replace their private health insurance, that the support for it becomes flimsy. But here's the interesting thing about private health insurance. So people love it until they have to use it. And that's just a function of the fact that thankfully most people who are privately insured are actually quite healthy, most people. Now, there's that minority who are not, who do have to use it, who usually hate it because using it means that you have to call them up and fight with some bureaucrat about what you already paid for. And we're starting to see a coalition of folks really opposing this policy and pushing this argument. And in fact, it is the Harry and Louise argument from 1993 when the Clintons really took this on. I want to understand how you.
Can I just say one quick thing about that? Because what's interesting is if you look at the polling, and we're doing some new polling in 32 swing districts across the country, it's looking very, very good. What you see in the polling is incredible support in the 70s and 80s, 80 percentile range for Medicare-for-All. Then in some polls, depending on how the question is asked, there's a decrease if you say, do you want to get rid of your private insurance? Do you understand it would get rid of your private insurance plan? The support goes down. Why? Because people think that the doctor in the hospital that they like is tied to their insurance plan. Once you go back to them and you say, you still get to see the same doctor or hospital that you are currently seeing, it's just that you don't have to deal with the insurance companies, the support goes right back up. Because not many people want to deal with the insurance companies. Most people don't have good experiences with that, unfortunately. And so there's a real nuance to how you talk about this and what you say and what the attacks are said to be, and then what the truth of the situation actually is.
Yeah, well, you answered my question. Thank you.
Oh.
We're starting to see a lot of folks come together to push back, and it's the usual suspects. It's the CEOs and their hench people who make tens of millions of dollars profiteering off of people's bodies. And they've come together and said, well, we have to warn the American people about what this might do to them, which is more a warning about what it might do to their earnings. I'm showing my cards a little bit here, sorry. And I wonder what it will take to be able to beat that, because in every effort that we've seen toward a universal healthcare reproach in any way, whether it was Truman or it was the ACA, we've seen this real investment of serious dollars to try and defeat it. What would it take to actually see this legislation passed in terms of the way this fight actually plays out?
Well, it's true. If you look at the lobbying accounts of the top pharmaceutical companies and insurance companies, it's tens of millions of dollars that go towards congressional candidates. I don't take any corporate PAC money, and more of my candidates are joining me. But that is what, frankly, a lot of your premiums go to is that and the incredible amount of profit that gets made. So $90 billion for the top 5 insurance companies in profits, $75 billion for the top pharmaceutical companies in profits, and nobody is denying profits. Frankly, if they hadn't been so greedy, I don't think we would necessarily be at this place. But the incredible greed of continuing to increase pharmaceutical drug prices for something like an EpiPen or cancer treatments or insulin treatments to the extent that they're unaffordable has put us in this situation. So what does it take to win? I think that we are in a very, very unique moment in this country where the majority of Americans are feeling a healthcare pinch. Even if you have employer-provided healthcare, what you have seen, if you look at all the research, what you see is employer insurance premiums have gone up, also, just like everybody else's insurance premiums, which means that they are having to put more money into paying for employee healthcare, pushing many of those costs down to their employees. And one of the reasons we were able to get a lot more labor unions on board this time around is because it's also leaving wages on the table, right? I mean, if you look at the wage stagnation, one of the reasons for that, a pretty significant one, I think, is that if you're negotiating at the bargaining table and the employer says, I got $1 for you, and you got to decide what you want to do with it, if you have to put 60% of that into health insurance, then you only have 40 cents left for wages. So there's a lot of money that's being left on the table for wages because of this. And there are a lot of employers now, small businesses, medium-sized businesses. We have a great coalition that's been formed called Businesses for Medicare-for-All that are making the business case for why we are losing out competitively with the rest of the world. Because other industrialized countries are paying for the health care of their employees. And so people are not tied to their employers. They can move around. They can start small businesses. They can be innovative. And all of the employers are having to pay for insurance on their bottom line, out of their bottom line, that their competitors in other countries are not. So it's affecting our competitiveness as well. So I really feel like the way we win is by continuing to build these strong coalitions, continuing to build the grassroots movement across the country. We have labor unions, we have businesses, we have regular folks telling their stories. This is so powerful. The GoFundMe insurance plan is not an insurance plan. And so if you look at the trajectory of the movement 5 years ago, it would have been hard to imagine that we would be having this hearing in the House. But several things happened. Number one, the Affordable Care Act passed. And the Affordable Care Act not only expanded care for tens of millions of Americans, but it actually changed the mindset so that Americans started to believe that we deserve this. yes, it's a human right, but it's more than that. We actually deserve to have health care. And so that made a big difference, because before that, people didn't see healthcare as a human right. Today they do. So that was very important. And then when Bernie Sanders ran and he elevated it to the presidential level, it made an enormous difference. And then third, the attacks on the existing healthcare that is stripped away so much has made it a top issue for everybody. People see that they can't go to bed at night and not worry about going bankrupt or foreclosing on their home. People see, doctors see patients walking out of the emergency room even though they know that they have been told that they might die if they do that, against medical advice, right? AMA, walking out even though they've been told by a doctor that if you walk out without this treatment, you may die. So I think that's the energy that we have, and then of course Democrats taking over the majority, and the Progressive Caucus, of which I'm co-chair now 40% of the entire Democratic caucus really pushing this issue and leveraging our power to make sure that we get a hearing and that we move the bill forward. I think all of those are part of what we're seeing as the real success in how we pass this thing.
I think the other really interesting experience that I came upon when I was running in Michigan was that when you would talk to folks, even on the other side in some of the reddest districts in the entire state, they understood implicitly what it meant to lose health care because, of course, Michigan suffered the recession worse than almost any other state. And so if you said, listen, what if it meant that if this were to happen again, you wouldn't have to worry about where you would get your health care? That's something people understood. And what was crazy is it operates not just on the lived experience side of the people you're talking to, but also you talk to a GM, when they were negotiating their bailout, they were paying at that point 15 cents on the dollar for every dollar that they took in selling cars, not just to pay for a current employee health care, to pay for retiree health care.
No, that's right.
And a lot of those jobs that got offshored, you know where they went? Canada, because they have universal health care.
Right.
And people understood how that worked because they lived through it. And I think that experience of the Great Recession has moved a lot of people's minds. I want to move to some questions from the audience. Before I do, though, I do want to thank the incredible staff at SPA. Can you just put your hands up, please? Thank you for putting on such an incredible event. And of course, the incredible leadership of Dean Wilkins. It's been an absolute privilege to spend some time on campus, to work with your incredible students, to have conversations about who we are and who we want to be, which I think is at the core of the question of politics and policy. So thank you so much. All right, so let's take some questions. All right, I saw Kamran, and then I see the gentleman in the back, and then I see the gentleman in the front. I saw all gentlemen. Any other questions?
There's a lady.
The young lady in the back. Whichever you'd like.
Okay, so basically, a few weeks ago, I went to Senator Gillibrand's town hall and asked her if she would commit to abolishing the private insurance industry. And I told her, look, like I've got an implantable defibrillator, so my parents' income determined whether or not. I would be alive today. And when she answered, like, she didn't commit to abolishing the private insurance industry because she said that she saw the transition to Medicare-for-All. She saw that the transition would include a public option. So my two questions would be, what do you think the transition to Medicare-for-All will look like? And two, what would the effect of Medicare-for-All be on medical technologies like a pacemaker and stuff? Thanks.
So in my bill, we propose a 2-year transition, and some people say that's too fast. You can't possibly do it. I would just remind you that Social Security, that Medicare was established and set up and running in a year. But in addition, thinking about the transition is a very critical moment. What has to happen during a transition? If you keep the transition too long, it means you've got to keep the existing system in place. And it makes it very, very difficult to keep an existing system in place when you know that it's going to have to end, right? That's going to drive premiums through the roof. So keeping the transition as short as possible is actually very important. Second part of that is the administrative savings. You don't recognize any of the administrative savings if you've got to keep everything in place. So you really need to make that transition fairly quickly. So what we've said is, first year is aligning all of the systems. Remember that the Medicaid, Medicare systems already are there, they exist, they're computerized. The employers already have it all on computer. So aligning those systems is very, very important. Everyone else is getting added in. So we think the first year is about aligning the systems. The second year is testing it just to make sure it's working. So that means we're proposing 19 and under and 62 and over would be covered. And then by year 3, we would cover everybody. In terms of, this is the most comprehensive coverage. And so the technologies that would be necessary for people to live would be covered. And you wouldn't have to worry that your family didn't have enough income to qualify, or that you had to somehow become so poor that you could qualify, which is also, by the way, happening. People are, the latest, not latest, but the thing I hear about a lot now in town halls is people who are getting divorced so that they can meet the Medicaid threshold for poverty. So, just on the abolishing of the private insurance company, I want to be very clear that we are not abolishing anything. What we are saying is that Medicare-for-All will be a comprehensive plan, and insurance companies cannot cover the same benefit, cannot offer the same benefit that is covered under the plan, which is actually how Medicare works today. Now, in the technology world, this would be called market disruption, and everybody would celebrate it as an innovation in how to bring down costs and provide more access to care. So let's be disruptors. The insurance companies will have to think about what else they can do. They of course can exist, we're not abolishing them, but they just can't provide the care that we're providing in Medicare-for-All. They can provide cosmetic surgery, things that aren't necessarily covered under our plan. But I think that's very important. And then the other thing I want to say is there are a lot of people who work in the private insurance industry. We have thought very carefully about how we take care of those folks because we think they're very important. And so there's about 1 million people that we think will be displaced if Medicare-for-All happens. We have set aside 1% a year of the total cost of the bill for 5 years to take care of a transition for those employees in the private insurance sector so that they can either, if they're able to retire, that might be one, pension guarantees, job training, they can move into a different system. So I want to be clear that I'm not concerned about the profits of the insurance companies or what happens with the stock market, because the majority of those profits go to the top 1%, they don't go to the average person that's on the street. I do care about the workers within the insurance industry, and I want to make sure that we take care of those workers and provide opportunities for them to transition.
I just want to make a comment on the term public option. So I hate to say, there is a lot of purposeful misappropriation of the term Medicare-for-All. And anybody who tells you that Medicare-for-All includes a public option either does not understand what Medicare-for-All is or is purposely misusing the label. You can take that as you like. As far as tech, the question, oftentimes people assume that somehow, unless you have a complete open market, that the incentive to innovate goes away. The thing about it, though, is that insurance markets do not drive innovation. In fact, they stifle innovation. The reason why is because they already ration what's available. They just do that so that they can maximize how much money a particular C-suite makes and shareholders make. They're actually quenching what's available because their bottom line is completely divorced from the well-being of their patients. Whereas under Medicare-for-All, frankly, the entire country, the system saves money when people are healthier. So things like your device, those things keep you a lot healthier than the alternative. We need that in the system. And because there's alignment between the basic research that we do, that is, by the way, mostly government funded, and what's delivered in hospitals and clinics across the country, that alignment allows for a far faster transition into actual care. So when people say, well, look, our high quality healthcare is going to go away because you're not going to have a market that drives innovation, it's garbage. The payer model does not drive innovation, it's the provider side. And in this system, there's so much more efficiency that can be wrought. I saw the question back.
Your system, well, thank you for
Yeah, absolutely. And just so everybody knows, bills are never scored when they're introduced. Very rarely do you ever have a plan. I don't remember seeing a plan for how we're going to pay for $2 trillion Republican tax cut, by the way. So that's exactly, it wasn't paid for. You're absolutely right on that. But I just wanted to make a point that when you introduce a bill, you rarely have a paid for on the bill. Sometimes there is, and it's very rarely scored until it's ready to go to the floor. That said, there have been a lot of estimates, cost estimates, which we can talk about. But I just wanted to ask a question. Who knows how much we spend currently on healthcare in this country? 18.5%, correct. And anybody know what that costs? 32 trillion. Our bill, and do you know what it's going to cost if we just continue doing what we're doing? Do you know what it's going to cost in 10 years? Anybody? 50 trillion. You guys are so good.
So
50 trillion, exactly. $50 trillion. The estimate that a conservative think tank, and he actually came and testified today, and he did pretty well, and I thought he was like, actually we agreed on a whole bunch of things, including that we would save money by implementing Medicare-for-All. He himself said that. He said it would cost $32 trillion over the next 10 years. Well, that's $18 trillion less than $50 trillion over the next 10 years. So our plan would save money. But then on top of that, it's important to think about what we're talking about. We're not talking about 32 trillion of new money, which I think is what you were getting at. Currently, 2/3 of our expenditures are already paid for by the federal government because of Medicare, Medicaid, and private subsidies. So those payments would continue to be there. And let's say let's say it's 3.2 trillion, and I'm just taking their numbers just because that's the only numbers that are really there, and I could quibble with them and argue with them, but I'm just going to accept them. And let's say it's 3.2 trillion a year. 2/3 of that is already paid for. We're paying for it now by the federal government. That means that we got to come up with about $1 trillion, that last third, about $1 trillion. There are so many ways to come up with that $1 trillion. As it is right now, employers are paying about $650 billion in insurance premiums per year. So that's one easy way. We could just take a portion of that, pay it towards the federal system so that an employer pays a tax per employee to the federal system, and they're covered. And to the point of this is not a partisan issue. The sickness in America around healthcare is not Republican or Democrat, it's everybody. And I have Republicans come up to me and say, I disagree with you on a whole host of things, just about every other thing, but could you please pass that Medicare-for-All bill? Because we really need healthcare and we cannot afford it. So these employers could pay in, but you can have a wealth tax. You can have a very easy wealth tax. Elizabeth Warren has proposed a wealth tax. There's financial transactions tax. There's all kinds of ways if there's a will. We spend $733 billion as the proposed number for military spending. There's a lot of money out there to do the things we need to do. We just have to have the will to do it. So we will put out a white paper with several different options for how we could come up with that last third, and to make it clear that 2/3 of the cost is already being borne by the federal government. We really only have to come up with another third. I'm sorry? Yeah, I think we'll probably do it in the next couple of months. But I think that the cost, before I answer the cost question, I always ask people what it costs today, because you sound like you're a really knowledgeable person. You probably already knew that. But a lot of people don't. A lot of people think that somehow it's free. The average family today that has health insurance on the marketplace is paying $10,000 to $18,000 in out-of-pocket costs. It's coming right out of their pockets. So in premiums, copays, and deductibles. So the idea that we're not already paying for it is just crazy, and we just have to help people to understand what the costs are right now, and then show that it's pretty easy to cover it.
The other thing just that I'd like to add is just that most folks don't understand what $32 trillion. I don't understand what it is. Like, you ask me, what can you buy with $32 trillion? I'm like, I don't know, a lot of stuff, right? And so when we talk in those astronomically huge numbers, we actually do a real disservice to the conversation, because most folks don't get a concept for, like, all right, what's 32 trillion relative to the full budget of the United States government? How does that budget change? How much of that is going to get swallowed up over time? We don't have those conversations. The conversations that we do have, that all of us have, is how much do I pay in healthcare? How much do I use healthcare? And what's this going to do for me, right? That's the way we should be talking about how we pay for Medicare-for-All. Right now, if you're one of those, 40%, right, for whom you're not paid for by either Medicaid, Medicare, or subsidies, if you're one of those folks, you probably have it taken out of your biweekly paycheck, some amount that you don't really know because you don't budget into it because it just gets taken out. And the question that we have to ask is, well, if that was replaced by a payroll tax, what's the user experience and difference? Actually, you're getting money back. So when we pushed out Michicare, our single payer program in the state of Michigan, we calculated that the average family of four earning $48,000 a year would save about $5,000 all in. The only folks who were paying more were folks who were making more than $150,000, and they were paying slightly more. And then corporations were actually saving a tremendous amount of money because instead of having to self-insure, they were just paying a tax. And so the user experience part's really important. The second thing I'll say on that is we finance wars without asking how we're going to pay for it. Trillions of dollars in war material that end up in effect becoming jobs programs in Ohio. And we finance them by being willing to take on, in effect, national debt. The question we have to ask is, well, are we willing to do that for things that are actually valuable for us? And we can talk about the value of war if we'd like, but that's a different question. And so, this cost question, I think, is a little bit of a canard because we assume we're like any other person. I make this much, I spend this much, and I've got to make sure I make more than I spend. That's just not the way that federal government economics works. Anyway, so...
I just wanted to ask my questions because I think they're really quick. First of all, I'm a big fan of public insurance. I'm a small business owner, and I'd never have been able to start my small business without the ACA. So for me, this is a question not about does everyone deserve health care or do we need to get off the current system, but it's a how question. So I have some basic questions about how. The healthcare system is actually multiple healthcare systems. One of them is the VA. So in your bill, I assume, Congresswoman, the VA stays as is. It's not a
We
part
keep
of
the
the bill.
VA and Indian Health Services separate.
And so my second question is about Medicare and Medicaid. So today Medicare is administered at the federal level, and it seems from what I've read that would continue, so it's effectively an expansion of Medicare. But Medicaid is actually administered at the state level, and so my question is about what happens to all those Medicaid state agencies, the CHIP agencies, how does that work? Does that get rolled into CMS, or what happens?
Yes, it would all get rolled into one system. And we think that this is really important, right? It is Medicare, but it's an expanded and improved Medicare. We didn't really talk about this, but there wouldn't be Medicare Advantage plans that you'd have to buy separately because vision, dental, all those things would be covered within Medicare. So we're taking the existing Medicare system, we're expanding it, we're tying it together with the Medicaid system, and then we're administering it universally.
So just one final question. As a ballpark, does that mean that CMS doubles or triples or quadruples? I mean, what's the order of magnitude of how?
No, actually, I mean, what's interesting is that the costs for administering the Medicare system, any government system, are way less than what we're paying today. I mean, we have way fewer people, we have way less costs. So we're not anticipating that we're going to end up, needing to, in terms of administration, significantly expand. Now, in terms of the numbers of people that are coming into the system, of course, we'd be covering the whole population. So, yes, it would be a universal healthcare system, which, by the way, is something that did I say this already? That every other industrialized country in the world does, except for the United States. So, we can do this. We really can do this, and we have a lot of systems in place. When Medicare was first established, there was really nothing. There were no computers back then, even. But now we have a system that is already adding tens of thousands of people every month, actually, into the system as we age, as our population ages. This is saying we can expand this to everyone. I'm not saying it's going to be easy, but I'm saying it can be done.
So just on a note, this is not on this particular bill, but there are when we talk about Medicare as it stands, it's actually not directly centrally administered. There are private administrators that are regional. And thinking about the size of CMS, the question of how much of that would sustain is an important question, because what tends to happen is, if you just look at the on the ground reality of it, is that you have these arms of private insurance companies that in effect work in bulk for the government to operate not Medicare Advantage, but Medicare itself, that in effect that part of their business is also subsidized by the private part. And so we have to ask questions about what the actual administration actually on the ground looks like. Personally, I've been thinking a lot about it, and I actually think that maintaining a state-based model is actually not a bad idea. Because you already have that infrastructure, and in terms of a rollout, it's sort of like a parallel process rollout where you just have 50 states who are all kind of rolling it out at the same time, and CMS becomes a central both administrator of that oversight and also a consultant in support. And because you have the rollout, just thinking like reality of politics, you have 50 different processes happen at one time. And so you don't have the scenario where you potentially have the healthcare.gov turmoil, right? Where you have one rollout, it goes poorly, and everybody's like, see, doesn't work. Versus being like, well, that was Maine, right? Maine always gets it wrong. Michigan did it perfectly. Anyway.
Washington did it better. I just want to make a point here that we can get into a lot of these details can be worked out, okay? We can get involved in the technical details of how this rolls out, but the first thing that has to happen is we have to say that we want to do it. We have to say that we believe it is a human right. We have to say that everybody should get health care, and then we can continue to work on the rest of it, but there are certain basic premises that have to be addressed first. And sometimes the details, I know people, they're important, we should talk about them. Our bill has a lot of detail in it. We also leave a lot to the Secretary of Health to determine as we go along too. So there are different pieces of it. You have.
Thank you so much for coming. And as someone who spent the first 3 months of this year arguing with my insurance company over life-saving medication, I'm very supportive of Medicare-for-All. So my question is more of a political process question, which is I think one of the big failures of the Affordable Care Act was that it was passed, you lose control of the House, and suddenly all of the technical fixes that you kind of do if you are in control of both chambers, you can. So you have to wait. So the administration's like, oh, we're going to delay this, we're going to fix this. It goes to the courts pull a little piece out here, a little piece out there, and it kind of just becomes half baked, and it's just kind of a mess. So how are you building this bill to both be constitutionally bulletproof and also roll out in a way where it cannot be sabotaged in the short term by a Congress that might flip, or in the long term by an unfriendly administration?
I mean, it's a great question, and first of all, I'm sorry that you have to deal with insurance companies on your life-saving needs. That just shouldn't be the case for anybody. There is no way to make it bulletproof. I mean, we have a democracy. The democracy means that you can change things through legislation, and that different parties come in and they change things. But what is bulletproof is if the American people support an idea, then it becomes somewhat bulletproof. What's interesting about the Affordable Care Act is it wasn't that popular until people had it. Once people had it and you tried to take it away, it became pretty bulletproof. That's how we defeated Trump Care. We have not been able to defeat the attacks on the Affordable Care Act completely, and so you see on any number of things what's happening and the ways in which it's driving care down. So I don't have a good answer for you on how to make it bulletproof. What I can say is, if we can develop a system that truly does provide universal care for everybody, that is the best way to make it bulletproof. People do not want to have things taken away from them. Once you provide them, there's a lot of angst going up to the provision, but people don't want to have things taken away. Once they have health care and they realize it is possible, it is necessary, it is right, then it becomes very difficult to take it away.
That's also, I think, partly what's brilliant about a 2-year rollout, because if you think about when it'll get passed, if you just follow politics, it'll probably get passed within the first 2 years of the first administration. meaning the rollout gets done within that administration. The worst possible scenario is you're halfway through a rollout, then you switch parties, and then you're in a mess. So I think folks argue against how long the rollout happens. Beyond the policy, there's a really important political question to be asked there too.
Just a quick follow-up. I saw that there's 108 Democratic co-sponsors.
109.
109. How are you going to get the other 120-something?
Oh, you have not seen me work. We work very, very hard. This is double the number of double the number of original co-sponsors for any other single-payer bill on introduction. And we are going to continue, HR 676, which was a fantastic bill that John Conyers put forward, really a blueprint, not a detailed plan, but a blueprint. That by the end of the 2-year cycle had, I think, 126 co-sponsors, started with something like 56. So we are in that process. We can't get it done without you. And people like you and others in the audience telling your stories, organizing in your communities, getting your reps to sign on if they're not on, that is how we get it done. I mean, this has to be a movement thing. It's not an Abdul and Pramila show, or, well, I'm putting him into the
Pramila and Abdul
mix,
show,
but
let's be clear.
it really has to be a people's wave, a people's movement that makes it happen. And so that is, there were 300 nurses lobbying yesterday at the Capitol from 28 states. People's Action had 1,000 people in town. I think I spoke to like 1,700 people yesterday at all these multiple events. And that is what it's going to take. Is your representative on board? And how do you get them on board? And who's talking to them? And who's telling their story? It's not just Republicans, it's Democrats too. We have more Democrats to get on board. If we can get to 160, that will be a really important mark for us. And so we're continuing to work on that, and I'm pretty confident that we'll be able to get there, but not without you. No pressure.
So
you can
I
tell
think
Congressman Nita Lowey that I'll vote for her primary opponent if she doesn't sign on in that case.
So I think, unfortunately, that's all the time we have. We have a hard stop at 8:15. If we can get another round of applause for Congressman Jayapal. And one more hearty round of applause for all the folks who made this happen at SBA.
And for Abdul El-Sayed.